here today.
Doctor, thank you very much. We're joined, I should note, by Representative Black and Representative Schwartz. Thank you both for your interest. Reading through the testimony, and I appreciate you getting it to the committee well in advance so we could study it. You know, it seems to be clear that you're convinced we can base payments on quality measures, that getting those measurements right is very important. The collaborative approach in which, you know, a physician who's isolated is going to have more trouble than one that's in a system that gives them timely feedback so they can continue to make the adjustments to quality care, and that it's important that as we create this formula, we not only reward physicians for improving the quality of care, but we also reward them for maintaining a high level of quality of care going forward. Let me start with my first question, Dr. Cornier. And I say to all of you, I like the process that we've taken here, where we continue to share the framework of where we want to go, seek input from you, you know, in 2 different rounds of input. I hope that's working for physician organizations. I think it's going to create a better product at the end of the day. But Dr. Cornier, you've been doing this for 20 years. Your own experience, 13 physician practice. So that would translate to many of our communities. One of my concerns is heaping another round of quality indicators and paperwork and bureaucracy on top of physicians who are not only struggling with a dramatic increase in paperwork and overhead, separate quality indicators from private insurance as well, a lot of bureaucracy with electronic medical records. So my question is, can we achieve this without adding more burdens onto local physicians? In your experience at Health Partners, have you focused on the key indicators that matter rather than a laundry list that may have various value?
Boy, we sure have tried to. And I think one of the consequences of an engaged and collaborative approach to doing this is that the provider organizations in our community and our marketplace have held us accountable to a commitment as health plans in our market to use those agreed to measures, not create the kind of confusion that can occur when Health Partners, Blue Cross Blue Shield, and Medica and others in our marketplace have little variations on the same general principles. We have agreed as a market on things like comprehensive diabetes measures, where actually achieving the goals and the clinical targets for those patients is the objective, but we all use those same measures as the foundation for any quality improvement incentives that we put in place. We also think it's important to have both process measures, those things that indicate whether or not you're on a day-to-day basis reliably delivering care in the ways that we know are clinically and scientifically sound, but also outcomes measures that are reflective of what's important to patients as well.
And that varies, I understand, looking at the graph you sent us, that varies by the type of medical care provided, is that right?
That's correct.
Good. Did physicians within the practice, do they have practices where they tend to focus on 1 or 2 of those types of medical conditions versus a broad range that would require you to keep up with a, you know, just a laundry list of indicators?
Well, you know, it's evolved actually. As a primary care physician, we don't really have the luxury of focusing on just one topic, although as we phased this in, we did get our feet wet, we got our skills up to speed based on, in our case, diabetes measures. Because we could create systems that reliably sustained performance on diabetes, we could then move on to other things like cardiovascular disease, preventative services, and actually manage a pretty long list, but do so in a way where the systems that supported us in doing that worked well. And we did that in a system that didn't have a big multi-specialty 1,000-member physician group to do it.
I'm not a fan of Washington picking out a regional model, injecting it full of bureaucracy and deeming it for the rest of the country. But clearly, your experience shows that there's the foundation in place that we can learn from. Is your belief that we can take approaches like yours and put them in place in Medicare in a reasonable time frame?
Yeah, I think this is a nice combination of a privately developed but collaborative approach to doing this work. And we do think that one of the real values of that is that provider groups could look to the health plans who are driving towards a consistent signal in terms of clinical quality and the kind of incentives that they put in place, and take the risks to make the changes that they needed to drive towards better performance on those selected measures. Anything that CMS can do in those regions, and I think that those regions exist all across the country, to reinforce those signals without interfering with some of that work that's going on would be a delightful translation of that work into improving quality for the patients who are served by CMS and Medicare.
Great. I actually have a boatload of questions for all of you, but for the sake of time, let me yield to Dr. McDermott.